Hi, welcome to the Friday Research Seminar. My name's Jeff Bethel. I'm the Program Director in Epidemiology. We're glad you're here. Okay, so now to our introduction of our speaker. Matt Bozigar recently joined the faculty as Assistant Professor of Epidemiology in our College of Public Health and Human Sciences here at OSU. Dr. Bozigar earned a BS in Civil Engineering from California Polytechnic State University at San Luis Obispo, an MA in Geography from the University of North Carolina in Chapel Hill, a Ph.D. in epidemiology at the Medical University of South Carolina, and postdoc work at Boston University School of Public Health. Matt has experience researching the spatial, environmental, and social drivers of pediatric asthma disparities during his Ph.D. During his time as a postdoc, he continued his pediatric asthma work by studying geospatial characteristics of the built environment that influence the presence of indoor allergens and the effect of such allergens on lung function. Today, Matt will be presenting work from another project during his postdoc. Thanks.
Wanting to bring some
Clip the mic. Yeah.
That makes more sense. Is that okay? Audio? Okay. Thank you so much, Jeff. Thank you, everyone who was able to make it here in person. I would think there's also probably a fair amount of people on Zoom on this rainy day. So thank you to those in the ether on Zoom. I am super excited to be here at Oregon State University. I've hit the ground running, and I'm looking forward to meeting those of you who I haven't met yet. And I've really enjoyed meeting a lot of folks already. So Jeff kind of already introduced today's presentation that I'm going to give. So I am going to launch in here, and this is what I'll be focusing on today. First, I'll talk a little bit about me just because I'm new. So to kind of share a little bit about myself, and then we'll dive into the main event here, which is aircraft noise and health. And then we'll talk about that in the context of nurses' health studies, specifically the sleep study and the adiposity study that I was a part of. Then I'll provide some discussion and some limitations, strengths, and we'll be out of here. Well, some time for questions too. So now about me. So I was born and raised in Portland, just up the way here. Just up I-5. I'm a local guy, you know. So, and this is my circuitous path around the country, earning various degrees, getting various training, and now I'm back here, back in epidemiology, which is what I did my PhD in. So this helped kind of form who I am as a researcher, and I would be remiss to mention a really formative experience for me, which is taking a trip around the world. Kind of in that stage before my master's. So this is where I went. It was a 6-month trip. And this was a time when I began to really question places. What defines a place? What are the components that comprise a place? And how do they impact health? And so that's my motivation today as a researcher, is to support equitable and improved health for all people by quantitatively assessing the impact of place. And for me, so epidemiology for me manifests as kind of this at the nexus of thinking about the environment, social aspects, and the different spatial aspects about where you are and how that affects health. So my number one research theme is place-based influences, and that has meant that I've had to contend with multiple and multi-level exposures quite often. Big data is present and growing, and also having to consider how to do that. So methods to do that, epi methods. My second kind of main theme has been the drivers of health disparities. So not just that the question, do health disparities exist, but not trying to answer that question, but instead trying to answer the question about what drives those health disparities. For example, looking at indoor exposures in an asthma disparities cohort using electronic health records, which is the other project I worked on at my time at Boston University before this as a postdoc. So now I'm going to talk a little bit more about the main event today, aircraft noise and health. So first, we should ask what is noise and what is aircraft noise, because it differs from sound. Sound is the energy that causes changes in air pressure that can be sensed by the ears. Noise has an additional unwanted component. So it's unwanted sound, loosely speaking. So as you might expect, noise from aircraft is a type of transportation noise, the other big ones being road and rail in this country. And noise is commonly measured on a log scale, such that when we perceive about twice as loud, something twice as loud, that's about a 10 decibel increase. So, so it's not a doubling of the decibels that equates to a doubling of loudness. So something like 100 decibels, such as the inside of a subway train in New York City, is not twice as loud as something at 50 decibels, such as a large business office dishwasher in the next room over. It's way more than twice that. So in fact, it's 10 times that. And what we do in research and health research, when we are researching noise, is we're prioritizing the frequencies that people can actually hear. So, so that's a process called a weighting, called A weighting. And you'll see kind of in the rest of this presentation that any reference to decibels, dB, with that A, it should be assumed that that A is there if it's not in every slide. So just to be clear. So it's all A weighted in this research. There's different ways you can measure noise. So noise has a temporal aspect to it. So it's occurring over time. You can think about peaks. You can think about times it's above the, the 90th, I guess exceeded 90% of the time, or something like more averaged over time, which would be like a time equivalent sound level, which is there in the middle in orange. So this is, okay, great, this works. This is a screen capture of planes landing and departing from Los Angeles International Airport. And these are ambient noise monitors that are capturing the noise that the aircraft makes. Mostly it's capturing aircraft noise, could capture other ambient sources, but it's pretty clear that this is actually capturing aircraft noise as they pass by. And it generates considerable amount of noise, sometimes above 80 decibels or more. And this was happening, if you notice the timing, between 1 and 1:30 in the morning on a weeknight, which was, I think it was like a Thursday that I did this. And so the question is, what's happening below those flights where that noise is happening in the middle of the night? And are there health effects? The US Federal Aviation Administration, the FAA, has helped kind of develop, maybe not develop, but they have prioritized using metrics that can convert sound energies from individual operations into something that is more averaged over time, such that it can be standardized and used in research more easily. So that would be something like the day-night average sound level. So as you can see, all these different types of operations and the frequencies of them are actually all equivalent with this metric. So this would be equivalent to 65 decibels. So there's an inherent limitation baked into this, right? Because we might assume that there would be different health effects from these different types of operations. But the upshot is that we can use this and look at many different health outcomes in health research. So why do we care? How could aircraft noise possibly affect health, right? It's one of the questions I had when I started doing this research, which was new to me at the time. This is kind of one proposed model. So noise influencing stress response, activating certain bodily systems, and then influencing biologic responses subsequently, which we might capture in some intermediate outcomes, which are also risk factors for various cardiometabolic diseases. Okay, and so we're going to focus on two of those in this presentation. This graphic is a little bit outdated. This is reporting back to 2005, and this is only for 181 airports. There's a lot of airports in the world, in only 7 countries, and still there's 14 million plus people who are estimated to be exposed at a level of aircraft noise above 55 decibels, and that's by DNL metric there. And that's a pretty high actually level of aircraft noise on average for a place. Aircraft technologies, engine technologies have improved since then. So you've actually seen some reductions in how many people are exposed to aircraft noise, based a lot on innovations and emphasis on decreasing sound from engines, from aircraft engines. And yet, this is just kind of showing you that in just this swath, there's a lot of people who are exposed. I'm sure you've heard of aircraft fly overhead at some point in your day. Although interestingly, not as much here in Corvallis. One of the few places I've lived that doesn't have a whole lot of aircraft noise. It's not been that way at other places I've lived. So now I want to kind of pivot and start to talk about these things in the nurses' health studies. So the nurse health study cohorts, and a little bit of background too, which is pretty interesting. That these actually studies, so there's these studies that I'm presenting on today, but also other sister studies that were kind of on the health impacts and the economic impacts of aircraft noise. So really this came from Congress, and Congress is in this case requiring the FAA to enter into an agreement with a educational institution to do this research. So what ended up shaking out of this was that Boston University was selected to do the health effects. Massachusetts Institute of Technology was selected to do the economic impacts. And because we at Boston University want to use cohorts that were administered at Harvard, they also were some of our collaborators, some of the people in this T.H. Chan School of Public Health there. So about these prospective cohorts, these are the nurses' health study cohorts. You might have heard of them before, but if you haven't, these are large cohorts that have recruited over 100,000 people in each one of them, and they recruited female registered nurses at the time of their initial recruitment, which varied by cohort. And based on the differences in the initial recruitment date and the age at recruitment, the nurses' health study, the original nurses' health study participants are on average, about 20 years older than the nurses' health study 2 participants. And so for these studies, we were able to look at nurses' around 90 US airports. These are some of the biggest airports in the US. They capture 87% of enplanements in the US in a given year on average. And the size of the location is shown in the black dot. The size of the dot is proportional to how many nurses live around that airport. And we have good geographic coverage, and the US Census regions are shown in the different colors. And so we use some 2 main metrics for this research. So the first being what I mentioned before, this day-night average sound level. This has, as you can see at the bottom, in the bottom graphic, a penalty for nighttime noise of 10 decibels for noise occurring between 10 p.m. and 7 a.m. So it's got a mechanism to kind of capture noise that occurs at night because it tends to be a lot louder than ambient levels at night in particular. We also wanted to use a nighttime specific metric, which is the nighttime average sound level, L night. So you'll see these referenced throughout the rest of the presentation. That's particularly relevant, we think, for our sleep study. So we were able to get that, one of the first studies to use that, at least in the US. And so our collaborators at the US Department of Transportation's Volpe Center provided us with contours, noise contours, 1 decibel contours, both metrics that I just mentioned, above a level of 44 decibels. and that's for 5-year periods from 1995 to 2015. And they used the Aviation Environmental Design Tool, AEDT, to create those estimates. And so effectively, this is a representation of what we would have been given. And you can see that like a topographic contour, which is equal elevation, a noise contour is something just of equal noise. So if we know where the nurses were living, and we did, we could place their home address, use that to assign point and polygon geographic information system operation, the noise level in whichever contour they resided. Okay, that's how exposure assignment happened. Okay, so now I'm going to talk a little bit more about the sleep component of this study, which is its own type of study. So what is sleep? Sleep is a really cool, really interesting, dynamic, complex process that we all need for healthy brain and body functioning. It's particularly important for brain repair. Each stage of sleep is associated with a different slew of benefits, and there's people who spend their whole career studying it. And it was new to me at the time. I know a little bit about it, but so there's different dimensions of sleep as well, as you might imagine. And so one of those dimensions is sleep duration. We'd be particularly interested in those that sleep less than 7 hours a night, because that's been shown to be medically increasing risks for various complications and diseases. And then sleep quality is another dimension that we would be trying to capture. There's a validated tool for that, the Pittsburgh Sleep Quality Index. We didn't have access to that in this cohort. We only had, for alignment of the sleep and the aircraft noise estimates, one question on having difficulty falling or staying asleep. And for participants who said all the time, most of the time, or a good bit of the time, we said that they had poor sleep quality. So we're looking at short sleep duration, poor sleep quality. We have short sleep duration for 5 survey years. So we have repeated measures. We only have cross-sectional data for poor sleep quality. And we successively adjusted for different kind of buckets of covariates. The first being just a crude model, adjusting for the effects of age. And then subsequently demographics, some demographic factors, behavioral confounders, comorbidities, and also environmental confounders. And this is also one of the first studies of sleep on this scale to control for different environmental factors that were indeed found to be confounders of the relationships. So, okay, so for statistical analyses, we had, because it's a prospective cohort, longitudinal repeated measures data, and to account for clustering of answers and responses within participants over time, we needed some mechanism to do that. So we used generalized estimating equations. It's a fairly common approach for doing this in a prospective cohort. And within that framework, we looked at specific exposures that I previously mentioned, but looking at different cut points of those exposures. So DNL is not often studied below a level of 65 decibels. That's the basis for legal decisions in the US on noise abatement. Anything below that has not really been well studied. There's been one study in the BRFSS, that's maybe too many S's. There was a study on that was nationwide, cross-sectional, but they didn't look below 55 decibels, and they used zip code level assignments of aircraft noise. So we're talking about a very different study design. It's really the only other study that's kind of done this. And then another innovation was looking at any relationships with the nighttime specific metric for sleep. We also looked at effect modification by different factors to try to identify any potentially vulnerable subpopulations or just groups where we're seeing differential relationships. All right, so here are some of the characteristics of the study sample. So we had over 35,000 nurses. We're looking, I think it was probably clear in a previous slide, but only Nurses Health 1 for this study. In the next study I'll talk about, we loop in Nurses Health Study 2. participants. Most people are not exposed to aircraft noise at night above 45 decibels, but some are. And so we're looking at an age range, the average age being around retirement age at study baseline, which is the year 2000 for this study. So they're aging through the study from that average age. And we see a bit of a racial exposure disparity for those identifying as Black. Even within this cohort, this study is not kind of designed or even powered to look at these effects, but we did incorporate these and adjust for these effects as best we could. We found that for those exposed to nighttime aircraft noise, which is that right column, over 45 decibels, there was a higher proportion of people reporting diabetes and also hypertension. There were higher metrics of light at night in those areas exposed as well than for areas that were not exposed at that level, and also denser areas. Those were tended to be denser areas. We saw a bit of a descriptive relationship between more people reporting short sleep duration in the exposed group compared to the unexposed group, but not the same pattern for poor sleep quality. And now we're jumping straight into some results. So these are the results of our statistical modeling for short sleep duration. On the y-axis are the different exposure categories and metrics. So the top three are DNL, and then the bottom set is the nighttime metric. On the x-axis is the estimated odds ratios. So we're just showing the point estimates and the confidence intervals. And if we focus on the first cut point, so above and below 45 decibels, we're seeing higher odds of short sleep duration in the crude model compared to, for those exposed to aircraft noise at night, or I'm sorry, aircraft noise via DNL compared to those not exposed. That relationship attenuates a little bit, and it does actually include the null, but there's still a positive point estimate on that odds ratio in our fully adjusted model. So going from only age adjusted to fully adjusted for all those factors you see there. And then if we shift the cut point up and we look above and below 55 decibels, we see increased point estimate. We see a little bit more uncertainty because now we're talking about a smaller group. And we see a statistically significant relationship in our fully adjusted model. Those same patterns continue, attenuation through the levels of adjustment, higher point estimates, wider intervals. Now we're talking, we really are limited by the number of exposed cases for that cut point at 65 decibels, but a very high estimate of the odds ratio. And so when we look at the nighttime metric, the nighttime aircraft noise metric, we see increased odds of short sleep duration, in fact, 23% higher odds in our fully adjusted model for those exposed to nighttime aircraft noise compared to those not exposed. Given evidence of potential trend, we tested for that, and we found that using either metric, DNL on that left side, and the nighttime noise metric on the right, such that we found a monotonic increasing trend. So being exposed to greater amounts of aircraft noise being associated with higher odds of short sleep duration in this case. So now I'm going to pivot and talk about the other outcome that we looked at, which was poor sleep quality. In those same relationships, we just didn't see them mirrored in this outcome. So really, there was only a suggestion, again, at that 65 decibel threshold or that cut point of a potential relationship, though it still was just including the null. So for poor sleep quality now, tester trend, we're not seeing much evidence for that. Again, it's just kind of looking at the highest category of DNL. Maybe something's going on there. If you had a bigger sample, that probably would be significant. And I also have, I'm showing now our results of the effect modification analyses. So I don't think I described these previously. So we thought a priori there might be some potential effect modifiers of the relationship being region. So where you are in the country might have a role. in modifying the relationship. And whether or not you're near a water adjacent airport, the initial intent of looking at that was to see if by chance airports could preferentially send airplane operations over water during times people would sleep. That turned out to be a pretty faulty assumption though, because really that's driven almost solely by wind direction. So airplanes land and take off based on wind direction for the vast majority of the time, no matter the community concerns right now in this country. So, and then whether or not you're near a major cargo airport. So cargo operations are pretty different than commercial operations. They tend to be a lot louder because they operate noisier, heavier aircraft that can be also older with less noise reduction technology. And hearing loss. This is actually suggested by a reviewer, which I think was a great comment. And we're able to look at 2 survey years, but only for a short sleep duration. So if we were to walk through some of these results now, 83% higher odds of short sleep duration for people living in the West in this sample, compared for those who are exposed to nighttime aircraft noise compared to unexposed. So something may be going on there. Near the water adjacent airports, there were elevated odds as well. Near cargo airports, saw a large estimate of the odds ratio. And then for those experiencing no hearing loss or reporting no hearing loss. So if you can hear aircraft noise, you tend to be affected by it, which is a pretty strong argument for going into the, dipping your toe into the causal water, if you will. So for poor sleep quality, again, not really seeing those same types of relationships, with one exception, and that being for cargo airports, maybe a suggestion of increased odds, though not statistically significant. Okay, some takeaway points now. We found an independent association between aircraft noise exposure and short sleep duration, but not with poor sleep quality. So we also determined that it may be, in fact, important to include nighttime metrics of aircraft noise if you're studying sleep. And for effect modification, we found interesting results, right? So found greater associations, greater magnitude associations in the West for major cargo airports, for water adjacent airports, and for those with no hearing loss. So what do we think we're capturing when we find those relationships in particular? Probably underlying differences in the surrounding environment, climate zones, built environment, behaviors, model simplifications, particularly of the exposure model, so generation of the aircraft noise estimates. So if we were to try to propose some potential reasons for why we might be seeing this, which is just, we need more research to determine this, but what we think kind of internally maybe is that perhaps it's, you see differential relationships in the West because it's compensating for the East Coast driven business day. So you have the business day starting at differential hour compared to in the West, and perhaps flight timing and scheduling adjusts to that. It's hard to get some of that data. We tried, but that could be something to look at in the future. It's a drier climate, so at least maybe in the summer, there's different behaviors such as opening windows that are effective when there's not smoke around. Housing construction and type, so that could play a role, and just having kind of less ambient noise based on city planning and things like this could also be a role, play a role. So what about around major cargo airports? I think that's maybe a little bit more self-explanatory, but to kind of dive deeper into that, the AEDT model that I mentioned earlier uses the stage length method to estimate flight noise because it's proportional to how heavily laden an aircraft is. The heavier aircraft is, the more noise is experienced on the ground. So if cargo flights are being estimated, the noise from cargo flights are being estimated based on where they're going to land and how far away they're flying, that might not capture how fully loaded they are. And actually, takeoff weight in the US is proprietary, so we have no idea. So you could imagine, though, that fully laden planes flying shorter distances, you would have an effect that would show up as something that like what we found here. Around water adjacent airports, this one's a little bit, I think, more difficult to try to interpret, but there's suggestion that there's differential or just variable acoustics in those types of typically coastal or predominantly coastal environments, or at least on like large lakes. So that could be affecting the modeled estimates of the aircraft noise, which in the AETT model, again, assumes a soft surface at the receiver. And these are hard surfaces across which sound propagates more easily. There's also, onshore and offshore flows that can influence sound, ceiling heights of kind of how high clouds are. Things like this tend to be very variable around airports near the water. And then I think for the hearing loss evidence that we're finding is like the strongest for some sort of true effect, because for those who can hear it, you would expect that they would be affected more. And for those that cannot hear it, that association shows some suggested evidence as it's not being experienced, not a problem, aircraft noise for sleep. But it's only a limited number of participants, so we can't really say that very definitively. So that was the sleep study. Now we're going to look at another intermediate outcome, adiposity. And what is adiposity and how do we measure it? It's a question I got as the slides were just up before everyone came in by some of the tech folks. So adiposity is fatty adipose tissue. It's a fatty tissue. And so when we say use the label overweight or obese, that is referring to having kind of different levels of excess of the deposition of this tissue, adipose tissue. The simplest metric, or it's an anthropometric, but is body mass index, BMI. You probably heard of it. It is simply the body weight in kilograms divided by the height in meters squared. It's really easy to get, and particularly in a prospective cohort, who they can help self-report the components of that to calculate it. We also should think about where adipose tissue is deposited on the body. So this would be like what we consider central obesity. That if you've heard of like apple versus pear, like body types, actually apple body types in more recent research have been shown to be more at risk for certain conditions, heart conditions, things like this, than pear body types. So where body fat is held could be important. So we chose to look at that as well, specifically two metrics of that, waist circumference and waist hip ratio. Similar setup for the statistical analysis with a few exceptions now. So when we think about BMI, often that is categorized into what you probably have heard of as healthy weight or healthy BMI, overweight, and obese. And those are categories that have the cut points that are listed there, but are generally agreed upon by most kind of agencies across the world, whether it's WHO or CDC, things like that. But that means that we have an ordinal outcome. We have a ordered set of categories. So that therefore means we did ordinal regression. So effectively what we're doing is estimating the odds of increasing a category of BMI from exposure to aircraft noise relative to not exposed. For central obesity indicators, we chose cut points that the World Health Organization suggests that above which you are at substantially increased risk for various cardiometabolic complications. Getting tongue-tied. And for this study, we're only looking at the DNL metric. We decided to do the sleep study and the adiposity study totally independently. They have a very complex, intertwined relationship with each other. And there's different risk factors for each of those intermediate outcomes. So not so interested in the nighttime noise for this, but we are interested in the in the day-night average sound level. We had a lot more data available for BMI every other year in 2 cohorts now, and we had less frequent outcome data, at least for the 2 indicators of central obesity: waist circumference and waist hip ratio. We controlled for and adjusted for some similar confounders and covariates, but as the sleep study. But now, for example, we have new for this research, sex-specific factors that are confounders, some additional behaviors like diet quality and physical activity, and then also yet a different set of environmental confounders that we found. All right, so these are some of the sample characteristics for this combined study sample of the 2 cohorts. Almost 79,000 nurses. The vast majority of these, again, similarly, were not exposed to DNL above 45 decibels. And successively, with each 10 decibel increase, we're seeing some more, so fewer people exposed. And then by the top category above 65 decibels, there's only 69 people at baseline. Similar descriptive evidence of a racial exposure disparity. And also a suggestion that BMIs are higher in each successively higher exposure category. And for waist circumference and waist hip ratio, not quite seeing that same pattern descriptively. And these are our results for the odds of increasing a BMI category. Now, so going from say healthy weight or healthy to overweight or overweight to obese. And similar setup, similar colors and everything as the previous set of slides, odds ratio on the x-axis, categories of exposure on the y-axis at different cut points. So at the first cut point, 45 decibels, a pattern of attenuation as we adjust for additional factors, and then also seeing a positive odds ratio. So we're seeing greater odds of increasing a BMI group for those exposed to DNL at 45 decibels or above compared to below. That same pattern starts to magnify, or all those patterns. So we're seeing higher estimates, a little bit wider intervals, but a significant effect of aircraft noise on increasing a BMI group. And again, similar pattern with more uncertainty, a low number of exposed cases is the main driver of that. So we also looked for a trend in this work, and we found that there was indeed a trend, perhaps a more linear trend. And tough to say what's really going on in the group that's highest level exposure, but we would presume that if we had some more folks, that would probably maintain. Now switching over to some of the indicators of central obesity, not seeing kind of the same thing. So this is waist circumference at that cutoff. Particularly when we get to our fully adjusted model, that last step of controlling for the environmental confounders kind of gets us just null, very null. So same story for waist hip ratio now, more or less to waist circumference. All right, so a few takeaways from this work. Increased aircraft noise exposure was associated with higher BMIs. What I didn't show you though is that in a change over time analysis, separate analysis, but similar, when we just looked at baseline exposures to aircraft noise and whether those were associated with different trajectories of BMI, it wasn't. So increased baseline exposures just didn't have a longer term effect of kind of changing trajectories. It was not associated with either the central obesity indicators, waist circumference or waist hip ratio. So there could be some reasons for that if we want to talk about that later, but in the interest of time, others have found that transportation noise and adiposity have been associated positively but there's been a lot of differences kind of, and the evidence is somewhat more mixed. And that's because a lot of the previous studies really focused on road noise. They were cross-sectional or change over time. And if they were change over time, is usually 2 time points only. And they were conducted mostly in European populations and mostly in Scandinavia, actually. And aircraft noise has been linked with increased waist circumference in a couple studies, only a couple. And then one other study found no association. And that's really kind of it for some of the big population health and aircraft noise studies, at least related to adiposity. So there's not much to kind of compare it to. All right, so I'm going to take a step back here and kind of try to start to wrap this up with some key messages. We found that aircraft noise was associated with these key risk factors that are risk factors for many chronic and cardiometabolic diseases, and those include shorter sleep duration and effects on increasing adiposity. Okay. There have been physiologic effects just on certain dynamics of the body as low as exposures as low as 33 decibels. So you can measure, there's been people doing, in sleep labs and things that have measured what happens when you are exposed to aircraft noise or simulated aircraft noise at a really low level, and you can measure biological responses actually in different ways. So we know it has potential to act at very low thresholds. And in the US, we have this kind of legacy of really only action above 65 decibels. And that is the minimum for legal action, particularly for abatement. So that means insulating your home from aircraft noise. You have a right to it above that level. This is all despite the fact that the WHO strongly recommends that DNO be kept below 45 decibels for general health, and for sleep health, that nighttime aircraft noise exposures be limited below 40 decibels. So we're kind of at this impasse now. So we need more research, but if we were to look at one kind of changing variable in our modern society, the quantity of cargo shipped by air has increased quite a bit in the last few years. That can predominantly be linked with changes in the way we buy our goods, e-commerce, Amazon Prime, right? Just think if you buy something on Amazon Prime, and I do from time to time as well, and you have one day, it's going to arrive in 1 day or 2 days. Well, the likelihood is that it's probably being shipped by air at some point, and that those flights operate around the clock. So those are the types of flights that are very loud, and we don't fully know the effects of those specific flights. Kind of know some maybe cumulative metric, right? That could mean that different populations are exposed, new populations, and to higher levels at maybe different ways. So where do we go from here? I think any research study is going to lead to more research studies, so that's one thing. But I think what we really want is, if we could, have even better, more accurate and objective measures, particularly of the exposure and the outcomes that we are interested in. And we need more of this in the US. This is really the first national scale aircraft study that looked within a cohort with these particular metrics and things. If we had an eye towards interventions, which we can't suggest, obviously, with the results of one study, but the things that you could do include noise abatement for your home. You could adopt new policy and adapt it as you find more information, as you learn from new information. You could innovate new technologies. This has been a good trend in the aircraft industry, I should say, to their credit. There's been a lot of innovation on reducing engine noise. Could be different innovations at the house level or even the personal level somehow. So this research definitely has some limitations, like all. So there's potential for misclassification due to the self-reported nature of the outcomes. They wouldn't have known that they were going to ever be linked with aircraft noise metrics, so it's probably not a differential in any way, misclassification for that reason, in a modeled exposure. So you were kind of have a crude aircraft noise metric, but we see population health effects even with that metric. We don't know which homes actually had noise abatement. It's possible some of the homes did have noise abatement, but that probably means that our estimates are likely underestimates. So in environmental epidemiology, that's often the case. You find some association. Because you can't control for everything, it's probably evidence of a bigger association. We're just looking within a pretty narrow demographic. It's an important demographic of older, mostly white women, but it's not representative of the US fully. And we lacked, I think, some key individual level data, particularly on things like noise sensitivity and annoyance would be probably a big one. Different things like sleep medications and chronotypes. So are you a morning lark or a night owl is another thing that we did not have. It's always challenging to include those things though. So I want to now thank my team that was like super instrumental in helping this research happen. In addition to our awesome team of collaborators, we had tremendous institutional support. There was a lot of people who contributed in real ways to this pretty big set of studies. And this is only two of a broader, maybe half dozen set of studies on this topic. And I'd like to acknowledge our funders as well. And thank you to all of you who showed up in person and online. So I'm happy to take some.
Question.
Oh,
Yeah.
go ahead.
Matt, sorry, which one? Thanks. Thank you for your presentation. That was really good. I had one question, but one quick comment. So I live in a really quiet neighborhood in Corvallis, and in 2017 we were in the eclipse zone, and it turns out there is some of your port noise when private jets are flying in.
Oh, wow.
So like
Yeah.
anyway, it turns out my house is so, but we have very good flights.
Huh.
Come into Corvallis.
Yeah.
So unless there's a major, but happening right in Corvallis. So I was curious, like these two outcomes, sleep and BMI, that relationship.
Yeah.
Yeah.
So we had a lot of discussions about that. And whether in our sleep study, for example, we would include in some way BMI in some capacity, and in the BMI study, sleep in some capacity. And are they acting through each other, one acting through the other, or vice versa? So I think that just because of the lack of a clear causal flow between those two things, like we had a sleep expert, Susan Redline, on our studies, and she was very hesitant to include both because it's just so difficult to understand which is leading to the other. So that's the best I can do with that. And I think maybe, you know, if in the future folks can better articulate how that all happens, great, we'll update our, you know, our studies. But so that's why we kind of just chose to do them separate. And there was a story with both, as you can see. So yeah. Mm-hmm. Yeah.
I have several questions. First, in the issue of sleep duration, there are some airports that actually have restrictions on night flights. Did you take that into effect at all? Because obviously, if flights suddenly start up at 5 in the morning, you'd expect sleep duration to suffer. Yeah.
That's a great question. San Francisco has policy that I know. So San Francisco International Airport (SFO) does have that. They stick out in my mind as an airport having a lot of online material about their community noise policies. They claim that they do have kind of some mechanisms in place to prevent excess exposures of noise to the surrounding communities, particularly at night. But I think if you look at some of the data that is available, there's a website called WebTrack, which is where I got that and that screen recording I did. that you can kind of day by day, you can look at even a crude histogram of when flights have happened, or the number of flights per hour at that airport, and in the time frame you specify. You can see that it mirrors other airports, other big airports that don't have those types of policies either created at all or trying to be communicated to the public via their website. So I think it's possible, but I think it gets caught up in the wash, I think, in the end. So, yeah.
Okay,
Next.
second question. You mentioned that exposure correlates with race. Exposure to loud noise in the adiposity.
Mhm.
But BMI also correlates with race.
Mhm.
So is the recognition that a greater exposure leads to greater BMI because of the exposure or because of race?
Yeah.
Any way to separate those?
That's a good question. Yeah, I think so. We have a different study that looked at using census data. This was a study led by one of the people by Dan Nguyen. Or I'm sorry, actually, no, that one was someone else, Matt Simon. Sorry, that was another study that looked at who is exposed to aircraft noise in this country, and actually found that Hispanic groups or people identifying as or being of Hispanic heritage were more likely to be exposed to aircraft noise than other socio-demographic groups, other racial groups too, in this country. But we didn't have data to really look at that. We really don't have much to go on with the racial groups that we have. We don't have a lot of racial diversity. So the best we can do, I think, is just to either adjust for it or find some other better proxies for the effect that race is having, because we know it's not directly tied to biologically like someone's race, right? So it's for some other set of a slew of reasons related to structural racism that we can't capture. So that it shows up in that way. But so if we could measure some of those other things better, that would probably be the better way to do it. But we resort to controlling for race.
Okay, my final question, again, about measurement. Is BMI really a good proxy for adiposity?
No, it's not. But it's one of the easiest and the only ones we can get in a population like this. So I think one of the things that's probably now a better time to talk about it is that we had metrics for those for most everyone for BMI, because people were willing to provide some of those data points. But when it came to waist circumference and waist hip ratio, the people who did not report either of those waist or hip metrics tended to have higher BMIs. So there was a selective reporting in this cohort of people just not wanting to share that. So those are the types of issues you run into in like a population health study. And so it's hard to get anything on people's weight and people's body shapes and things like that. So yeah, but it's crude at best, the blunt instrument.
We get one online. Yeah. Matt, will the exposure to noise from trains have the same effect?
Yeah, so there's been evidence found that I believe there's been studies that have shown effects of train noise on sleep. I think those have more of those have been in small labs, like actual sleep lab studies or like simulated noise from trains. But I would suspect there's some similarities. I think that there's a multispectral quality to aircraft noise that does separate it from other types of transportation noise. So the particular types of frequencies may have some sort of differential effect. So I think that's where you might see some differences, and also the frequency, it might matter. And so maybe planes are more regular, and you get one train a night or something. So maybe that drives some differences too. But I would suspect generally they'd probably be similar.
Or leaf blowers.
Leaf blowers.
There's case now.
Yeah,
Yeah.
exactly. All the time, it's talking about noise, and it's unbelievable.
Yeah.
Yeah, all right.
Other questions?
Hi, great talk, Matt. How do you think this would translate to kids? Like, is there any, I know you said y'all are doing the first like airport noise and sleep, but like, how other people look at traffic noise and kids sleep, or, I mean, they're supposed to have longer durations.
Yeah.
And they go to bed at, 6 or 8 or whatever, early.
I'm sure someone's done it, but I don't recall off the top of my head, and it's definitely a gap.
Yeah, okay.
Mhm.
There you go.
Yeah.
5-year research
Okay, there
program
it is.
right there.
Good to go. Yeah.
Thank you for doing this. We're glad you're here. It's nice to see stuff on place. I was really struck by the race data. And I cannot help but think that exposure in that neighborhood is also the same place where there are too many tobacco retail outlets and too many alcohol outlets and too much kind of gross food and not anyway. But we also don't have good measures for that either, right? Over time. So I'm curious sort of what you think, or whether hopefully you'll keep going on this and you can tell us about what's next and sort of layers of GIS data that you'll use. But
We don't know what's next. That's one of our issues at the moment, but we're trying to pair other noise sources with this. That's one lower hanging fruit, but that's actually extremely challenging in a cohort of this size because they're moving around constantly, not super constantly, but they tend to move actually locally more than they move long distances, these people in the nurses' health study. But just merging the estimates, like we have the contours, right? But that process of doing that like point and polygon across 100,000 data points with all the contours from 90 airports, and the individual contours of 90 airports, it takes a month. I mean, to do it for one cohort, and then you have a second cohort, and it's another month on top of that. So, so it's actually a bigger lift than it seems. It's like, oh, there's just add another noise source. That's challenging, but there's certainly ways we could look at other cohorts, right? And so cohorts of the inner city cohorts, for example, different ones that are out there. So yeah, things to think about, I guess. Yeah, Laurel?
Since this is a nurse's health study, I believe they collect occupational data and occupational exposures. So do they have the noise exposures that they have at work?
So a lot of yeah. So for nurses health study 1 for this time period, if we're looking at just this time period, for like the sleep study, for example, they're really retired, so they're not really. There's only a small fraction of them that are still working. The nurse health study 2 are more mid-career to end career and retiring as well. We don't have a good sense of what they're exposed to at work, other than the type of work they're doing and whether or not they have shift work. So that's another thing that we would incorporate.
There are exposure matrices for workplace exposures.
Really? Okay.
I can tell you.
Okay.
If you're looking for other sources of noise, because I would suspect it makes sense that the retired would have any workplace exposure, but in the workplace, it's time-weighted average, so your dose increases the more you're exposed throughout the day, and then if they're exposed at night, you would think that potentially also. I don't know.
I love it.
Okay. Yeah. Well, we should talk.
Yeah.
I think we're at time. So-
Thank you.